Hi, I'm Dr. Rafi Minasian. I'm a nephrologist from Los Angeles, and I'd like to thank American Nephrology Nurses Association for giving me the opportunity to talk at this annual symposium, which is their 50th anniversary. It's a big deal. I'm here to talk to you about ultrafiltration rates during dialysis and the issue of cardiac stunning. I've been a nephrologist for 30 years, and this is a subject close to my heart. As a nephrologist, I've noticed that there was very little attention being paid to this subject, and about 2010, a group of high-ranking people from around the country met to discuss the problems of why nephrology patients' outcomes had not improved substantially over the prior 20-30 years. And they concluded that the main problem was that we were missing the main point of the fluids, and the fluid problem can be summarized as a double whammy. And the double whammy is this, is that patients going on dialysis frequently experience the accumulation of excess fluid, which is their interdialytic weight gain. And then they have the second problem, which is they come to the dialysis unit and we take the fluid off of them at a rate that is not compatible with good cardiac health. So the double whammy is they gain too much coming in and then we take it off too fast when they're there. So let's talk about both of those things. The first thing is that when patients are gaining more than 3% of their body weight, they're already starting to put stress on their cardiovascular system. All the large companies have now adopted 5% increase in over your dry weight as a parameter that they want to avoid. However, actually the true increase in morbidity begins at around a 3% rise. Above 5%, it gets much worse. So that means if you're having a 70 kilogram patient, over 2.1 kilos, they're already starting to stretch their heart, and over 3.5, they're causing much more morbidity and mortality. And this is a problem usually of the weekends, and there's unfortunately a weekend every week. So we have this issue of small patients, particularly smaller statured people, and this is the most difficult is my small young women, 42 kilos, 45 kilos. If you only weigh 45 kilos and I tell you can only gain 3%, I'm only letting you gain 1.35 kilos. If in a weekend, that would be impossible. So this is the problem with fluid, is that if you're a small person, it's really hard to stick to these parameters, and that's who your biggest problems are going to be with. And if you had a 5% parameter on that same 45 kilogram person, it's only 2.25 kilos. So 2.25 kilos on a weekend is still a pretty hard restriction to maintain. And this all leads to the fact that there's no way around this other than to dialyze with less interval between treatment. And that's probably one of the main reasons that I'm a big proponent of home dialysis, because it's hard to get more than 3 treatments a week in a regular dialysis center. So again, the 3% rule or the 5% rule of extracellular body weight gain, above 5, mortality goes up quite a bit. Above 3, it's already starting to go up. So I instruct my patients that I want them to maintain their interdialytic weight gain below X amount of kilos, and I translate that to them in kilos so they understand what I'm talking about. The example of the taking the fluid off too fast, the second problem, might be best expressed as an analogy. When we talk about taking fluid off at a safe rate, that's like saying you're driving on the freeway at 65 miles an hour. And if we get 10 milliliters per kilogram of ultrafiltration rate, that's the 65 miles an hour. If you're looking at what's happening when you get to 13 milliliters per kilogram, which is now published and is being adopted by the large dialysis organizations as a parameter we should not exceed, and which now the federal government is now telling us we shouldn't exceed, and they're monitoring how often we do exceed that. So what's that 13 mils per kilogram? That's like going 75, 80 miles an hour. So you're already increasing your risk between that 10 and the 13, and the optimal would be if you were not taking fluid out at a rate that's taking it out of your blood vessels faster than you can refill your blood vessels. And so you know that when you do hemodialysis, you're sticking a needle into a blood vessel, and the fluid compartment you're drawing the water out of is just the blood vessels. So the vascular compartment is only 7% of your body weight, and you have to transfer fluid back into your vascular compartment. And that rate that it's being removed versus the rate that it's coming back into your blood vessels is where the problem lies. And if you can't refill at a rate that you're removing it at, you eventually deplete your blood vessels and you end up with hypotension and ischemia, and this is what leads to stunning. And the subject of our conversation today is cardiac stunning. All organs get stunned when the blood pressure inside of them is going down. So all patients experience ischemic changes, and in the gut that leads to leaky gut. In the heart, it leads to a process which results in scarring of the tissue, and it's microinfarction that's happening. And if you didn't know, all of our dialysis patients have a unique heart disease, and that heart disease is evident in post-mortem autopsy. When they look at the heart of a dialysis patient, they find that the muscle is scarred in a way that is unique, and that unique scarring is due to cardiac stunning from multiple hypotensive ischemic events that happen during their hemodialysis treatments. It's a problem which no other population has. And the cause of this is that we're taking the fluid out at a rate faster than the blood vessels can refill. So they took some patients and put them inside of an MRI machine during dialysis. And when that was done, it was noted that anybody whose ultrafiltration rate was above 13 milliliters per minute was already developing cardiac ischemia and cardiac stunning. This was not apparent to the patient, to the nurse, or to the doctor taking care of them. The vital signs did not reveal that. It was something that is completely occult, and it's happening during dialysis treatments every day all around the country. This problem is something we can avoid by just modulating our ultrafiltration rate. And when I talk about ultrafiltration rate and I talk about 10 milliliters per kilogram per minute, that's a 65 mile an hour on the freeway, which is normally okay. But sometimes it's raining and it's not safe to go 65 miles an hour, and you should slow down to 45. Well, there are some of my patients who over the years I have learned cannot refill their blood vessels at 10 milliliters per kilogram per hour. I have some patients who I've clearly demonstrated cannot even refill at 8, and I've had to take the rate down to 6. And when I get them down to that rate where they're refilling adequately, they stop cramping, they stop having hypotension, and they stop having post-dialysis fatigue and a lot of other problems. So you would not know that unless you were really paying attention to how much is the ultrafiltration rate and whether or not the patient is having a problem. And I've discovered that there are a few patients, and I'm going to say it's less than 5%, that have this much less tolerance for ultrafiltration. When you're doing ultrafiltration and we're talking about 10 milliliters per kilogram per hour, again, that's a 700 cc's per hour ultrafiltration on a 70 kilogram man. On a small patient, 45 kilos, that's only 450 cc's an hour. And if you're getting down to 450 cc's an hour and they're running 3 hours, you're only taking off 1,350 cc's in 3 hours. That's the safe rate. And they're coming in with 2.5 kilos on them. To do this safely, you need 5 hours. So I have also come to know that if I instruct my patients and I inform them and they understand the consequences of the fluid problems, and that I am not going to kill them. This is what I tell my patients. I say, I'm not going to write orders that I know are hurting you and killing you. So I'm not going to do that. And that means that when you come here with extra fluid, I'm either extending your treatment or I'm asking you to come back for an extra treatment. And once you start doing that with your patients, they understand that the only way to avoid me making their time longer or coming extra is for them to zip their lips and to control their fluids. And it's amazing how patients can be shaped to behave better by just explaining why they have to behave and then making them follow the rule that I will not kill you. And so if you put that rule in place, I won't go more than 13 mils per kilogram per hour, and they're coming in there, let's say another 70 kilogram person, and you're saying 700 an hour, and they come in with 3.5 kilos. Okay, 13 mils per kilogram per hour for that 70 kilogram man is 910 cc's an hour. I almost have to do 4 hours to get that 3.5 kilos off them. Well, they went wild on the weekend. They came in with 5 kilos. I'm still following my rule, and I'm telling them, okay, I'm going to have to do 910 cc's an hour, and it's going to take about 5.5 hours to do your ultrafiltration. They will not sit there that long. We'll probably decide that we're going to only take off 4 kilos today. They'll stay a little longer. We're going to leave some fluid on them. And the next treatment, they're going to stay long again. You do that to your patient a few times, and they stop gaining the fluid. It's just something that happens. I've seen it in my life, and I have excellent outcomes in my units for my patients regarding fluid. Really excellent outcomes. And one of the things that we're always doing, of course, is trying to keep their dry weights as low as possible. But I have a rule that my patients on ultrafiltration have a maximum that the nurse cannot exceed. And because of that, our patients are having an order written by the doctor that's essentially protecting them. And for that reason, I think my patients' ultrafiltration rates are kept safe because there's a rule that the nurse has to follow. If I leave it up to my nurse, even if I've talked to her and in-serviced her 3 or 4 times, I come back and I see, oh, they're going at 16, 18 mils per kilogram per hour. So the reality is the doctor oftentimes has to be brought in to write the completely strict order that says you're not going to exceed this ultrafiltration rate. And I would say that those are the main things I would like to convey today, that there is a maximum amount of fluid the patient should gain between treatment. And to get that down to the minimum, you want to shorten the interval between treatment, and that's a reason that we do a lot of home dialysis so that we can do more than 3 a week. And the second is you can't exceed the speed limit without consequences, and you won't notice the consequences when you're exceeding the speed limit. It shows up over time, and that's the cardiac morbidity and mortality that's unbelievably high in our population. And I believe personally that the biggest problem we have in dialysis today is our management of our patients' fluid problems. And part of the reason is because some of this stuff is inherently difficult to do. How do you really manage a 45 kilogram woman who only gains 2.5 kilos on the weekend, but only has 3.5 hours of dialysis? It's a difficult issue. And one thing that you have to learn is that there's a consequence to this fluid problem, and that you have to educate your patients in a way that they will accept what you're telling them. And a lot of patients believe that I gained 5 kilos, you took 5 kilos off of me in 3 hours, I was fine. But that's not fine. You know that 2-3 years from now, that patient's dead. That patient's cardiac status is going to be terrible. They're going to start with high blood pressure. They're going to end up with cardiac stunning. Their heart's going to get weaker, and over time, their cardiomyopathy is going to result in the fact that they went from hypertensive to hypotensive, and now you're giving them midodrine to come to dialysis. So that's the consequence. And you need to realize that it's a consequence you're not noticing when you're doing it. So if you're not cognizant of the things we're talking about today, they will completely go by you and you will not notice them happening. So limit your fluid rate of ultrafiltration. And I have to add one other caveat. What happens when that patient does come grossly fluid overloaded, 6-7% above their dry weight when they got to you? Well, my 13 milliliters per kilogram rule doesn't apply really then. They will refill their capillaries rapidly when they have that much external pressure. So from the point of view, when you're in an emergent situation, it is okay to exceed the speed limit for a limited period of time. But if you try to ultrafilter too fast for too long, eventually the blood vessels will get empty, the filling pressures will go down, and the patient will start to develop stunning. So I would only do aggressive ultrafiltration beyond 13 milliliters per kilogram for a limited time, something like half an hour to 1 hour. And all of these things I'm talking to you about today are to protect your patient in the long run. And it's easier to do the wrong thing in the short run. You have to teach yourself that you have to protect your patient in the long run. And like I said, you should not be responsible for conducting a treatment, the parameters of which are hurting your patient. Just the same way as I said, I will not write orders that will kill my patient. So the nurses have to be cognizant of when they're actually doing damage to their patient. The intention is good. You want to get the water off so they don't end up in the hospital with heart failure. But you're just letting them get away with that same behavior every week. You're not doing them a favor. You need to teach them, and you need to ultrafilter at a safe rate and shape their behavior so they're not causing the problem to begin with. I appreciate your attention, and thank you. This was Dr. Minasian.